within Europe, we try to really treat all our patients on cooperative study protocols. So it is almost, at our center at least, that it's very rare that a patient doesn't go onto study protocol. So saying that, the study protocol is obviously fixed, leaves less space for maneuvering between A and B, and there are certain rules which are very clearly set what to do if this and that happens. One very good example is that we have elaborate liver testing or demographic factors which deems how we're going to, which dose we're going to be using for asperginases, PEC asperginase in these patients. So, but that's fixed within the protocol, which is great that we have that. And we use these guidance to really give the patient the ideal therapy in that situation. So I think for patients between 18 to 55, I think the rules are fairly straightforward what to do with them and when to adapt to the comorbidities. I mean, the majority of patients in that age group are reasonably fit. It's obviously you have patients coming in with very severe infections due to leukemia, or they have a very unfortunate performance status due to comorbidities, but that's actually, I would say, in about only 10 to 15% where you have to take a slow start and try to overcome those challenges which are due to leukemia once you put the patient into remission. The more complicated patient group to treat is actually the ones 55 and older. Obviously, patients with that age group come in very different flavors. Some of them have had a very healthy lifestyle, have no comorbidities, and you would maybe inclined to treat them more aggressively. But we have shown in our studies that those patients have, despite a good performance status, still biologically are 60 and can't withstand pediatric-based protocols as good as someone who's 10 years younger. So, and then you have patients who have a lot of comorbidities, which are 65, 70, and it's pretty obvious that those patients to be treated with aggressive protocols is a huge challenge. The infectious death rate rises in those patients. The therapy, although we always try to treat them in study protocols or in treatment guidelines, quite often you see a patient that they can't get to that point that you can adequately give the therapy. And you also know that the prognosis of those patients is actually quite poor when compared to the younger patients, because at 2 years, about 20 to 25% will be still leukemia free. Whereas the younger patients you were talking about, particularly the IA group, which is 18 to 30, cure rates are in the ballpark of about 75 to 80%. So it's a very different way of actually approaching as a patient. I mean, so you would personally feel sometimes, okay, when you see that it's very difficult to get therapy in, you would incline to reduce therapy, to leave away elements that might be toxic to the patient, because you know that only 1 out of 5 will potentially be cured in that situation. So that is, to me, clinically the biggest challenge. And then once you get an age group of 70 and 75, it becomes even more complicated because obviously there are many patients where it is curing them at that age group with certain comorbidities makes it almost impossible. And then there are a few hand-selected patients that are able, even at 75, to go all the way, including an allotransplantation. So algorithms that have been published to assess physical fitness are become actually very important, and also mental fitness too, because the protocol is is a challenge for most patients. It is a long protocol, 2-3 years treatment. And they need a really good support team to get through that system. It is ALL is always treated with a cocktail of chemotherapy agents and steroids. So the majority of elderly patients will see something which is just a dose reduction, what you would do in the pediatric situation. So they will all get vincristine, you reduce the dose. All will get dexamethasone or some kind of other steroid. All of them will get some anthracycline. Everyone will get at some point cyclophosphamide or cytarabine. And hopefully we can get also in some selected patients also asparaginase to these patients, which is a very important drug for ALL, plus also methotrexate. But also all these substances you start doing dose reduction. So hence the cure rates can't be the same because you're reducing greatly what we know works. And then you learn as you're doing things, oh, you see someone getting methotrexate, although dose reduced, then you get renal impairment. So the second time you can't expose that anymore to the patient. Or they have a higher rate of toxicity with PMP problems in the fingertips. Oh, you start reducing vincristine. So, and that is all linked to age. And you very clearly you identify patients where you are at your limits. And then you have information, okay, you're not responding very well. You may put them into remission, but we know they are MRD positive. And those patients, if they have seen this cocktail, and they are at the end of the day, they are MRD positive, particularly the elderly patient population, where there's a higher rate of MRD positivity despite the cocktail, we know what's going to happen. They're going to be relapsing sooner or later, despite continuing the therapy in that context. So it's a real dilemma that we face.